Good afternoon, everyone. It's a pleasure to introduce Dr. Sarah Watson, our speaker for the day for our endocrine grand rounds. Dr. Watson is an associate professor in pediatric endocrinology here at the University of Louisville and a premier physician in the Wendy Novak Diabetes Institute. She did her school of medicine training here at the University of Louisville, did pediatric residency, and then went on to do fellowship at IU University in Indianapolis. She joined our faculty in July of 2014 and achieved the rank of tenured associate professor in 2020, I think. She is a very accomplished clinician and researcher, in addition to a number of leadership roles she has in clinical practice. She has also been one of our PIs and really directors, I would say, chairing multiple committees, both locally and nationally for the Idea States Pediatric Clinical Trials Network, which has had a lot of success in the development of clinical trials across the United States. And so this is a fantastic topic that Dr. Watson knows well. And so it's my pleasure to pass it on. She's going to speak today to D or not to D, updates on vitamin D evaluation and supplementation. Dr. Watson.
Thank you. So this is I'll just do the things I have to do first. So I do have participate in research studies as an investigator, and some of them are sponsored by pharmaceutical companies. None of them are in the area of vitamin D, but just to let you know, and I don't get any money from them, just the institution. So I've been working on a few studies recently that they're not to the point where I can talk about them with you today, but it has brought up a lot of interest in this area. So I thought we could talk about a little bit about vitamin D and just kind of, it likes to advance on its own. I hope I didn't accidentally set a timer on this. But to talk about the role of supplementation, the current recommendations for supplementation for vitamin D, and then also the role of vitamin D in disease treatment and prevention. I don't know that everyone likes history as much as I do, but I think it often kind of informs our perspective. You know, why did we first start thinking about vitamin D? And that context really informs our approach to how we have used it in clinical practice going forward. So I do want to start at the beginning. The rickets has been around for a really long time, even though we didn't name it rickets until the 1600s, right? It was definitely discussed, and it was even theorized to be due to some nutritional deficiency. And it was really in the early 20th century when they started doing some work looking at cod liver oil, and you could even call these early clinical trials where they gave some babies cod liver oil, which is very high in vitamin D, and looked to see if it improved rickets, which it did. So it helped prevent rickets, and they did that in England and then also in Italy. So you have a couple clinical trials at the beginning, but they didn't know what was going on with the cod liver oil that helped. Is that okay? Okay, thanks. So they, not too long after that, though, a biochemist started looking into what was in the cod liver oil, right? So this is Casimir Funk. He's the person who came up with the word vitamin. I thought that was kind of fun. So, so he helped identify the component of the cod liver oil that was helping, which was vitamin D, and then actually went on to join pharma. So he developed the first supplementation with this Oscodal that had was based on cod liver oil extract. So it had vitamin A and vitamin D. There was a Nobel Prize in chemistry that was given to someone else for vitamin discovery, but it was he was one of the people that worked on this project. So once they decided that they could make these vitamins, they became really popular. At the very beginning, they were really expensive. It was like $300 a pill, and in the 1920s, that was a lot, but it got cheap really fast. And it became really popular just to have bottles of vitamins on your dining table. So Frank Sinatra, this is an ad for Frank Sinatra's radio show in the early 1940s, which was sponsored by Vim's Vitamins. And he had a whole jingle. It's only fun because it was Frank Sinatra, but this is this is part of pop culture and where our love affair with vitamins and nutritional supplements came from. So if we want to, now that we know why we like to take these supplements, look at how often we have enough of the vitamin D and maybe take us a little more into the science of it. We still have a lot of vitamin D supplementation that goes on now. A lot of our patients take vitamin D supplements on their own. And then a lot of people come to us already having been prescribed supplementation after having been found to have low vitamin D levels as well. But the best population data that we have shows that about 28% of those who are 2 years and older take a supplement. So it is higher for little kids and older individuals, with less in the adolescent range and young adults. We even have about 3% of adults taking high dose supplementation. Now, this data is about a decade old. It's the best that most recent that we have, but it's from NHANES. But we get vitamin D from more than just supplements, and that's part of what makes it so hard to really assess all of these things. So vitamin D is not, we've talked about this before, it's not really a vitamin because you can make it endogenously, but you do get it from food and other sources. There also is variation in exposure to UV light. So you have variation, seasonal variation in how much you're going to produce from sunlight. So it is even harder to assess all of the endogenous production, which plays into how they came up with the recommended amount of vitamin D that we should take every day. So when they came up with the recommended daily allowance, they tried to account for all of these differences in sources and say, okay, well, let's look at the studies that were done in areas that don't have as much of the UV light, so low production over the winter, to try and account for that. And they also, a lot of the studies that they were looking at trying to see how much vitamin D do you need, the studies gave calcium at the same time. And that makes it a little more complicated to interpret because of the interrelationship between calcium and vitamin D. Everything is based on 25 hydroxyvitamin D levels. And so also, it's really confusing. I personally think that they give the measurements in the nanomoles and nanograms per mLs throughout everything, and they're so similar. So anyway, what we're used to seeing is nanograms per mLs, and but the recommendations are all based on maintaining that serum 25 hydroxyvitamin D concentration of just 16 to 20 nanograms per mLs, based on what we usually see from our lab values. And that we would all define as a low vitamin D level. But the reason that they use that is because that level is going to generally prevent rickets and bone disease. So this is based on their review of the literature, the cut points for disease. So if you have a level of less than 12, then you probably are going to have rickets or osteomalacia in adulthood. 12 to 20 is generally considered inadequate, but you don't really see the bone disease. And then you have above 20 is generally considered adequate. And then they even define that higher level is going to be above 150 or 60 nanograms per ml. Actually, they had some adverse effects. So it's not based on the same definitions, the same cut points that we usually use, but it's based solely on preventing rickets, which feeds back into the whole reason we looked at vitamin D to begin with, as we were trying to prevent rickets. So these are the levels. It gradually goes up. In the first year of life, you need 400, then you need 600 until you're 70, and then you need a little more because you don't make as much from the sun. So it's pretty easy to remember. So how many people actually get enough in their diet? And that is a different question. So the same NHANES survey, so still the data is about 10 years old, showed that the average intake was about 200 international units a day for men and about 168 for women and 196 for children. Generally, infants are supplemented at a little bit better rate, but they weren't included in this. So overall, the majority of men, women, and children get less than 400 international units a day. And that is all of the people that should be getting 600 to 800 international units a day. But they still get it from sunlight. Oh, I think it skipped one, except we don't really in Louisville. So, so that cut point for when you get enough UV light to make vitamin D outside of the summer months is the 37 degrees latitude. So we are in that area where the risk for deficiency is going to be higher because our patients aren't going to be making vitamin D in the winter months, only in the summer. Dr. Thrasher, Chattanooga, Tennessee is at a latitude of 35 degrees. So you probably, he asked me once if Tennessee made enough and I did not know. So I looked it up for him. Despite all of the risks for low vitamin D, not very many people have it. In general, most people have normal levels defined by our threshold of 30 nanograms per ml, but the 18% had a level between 12 and 20, and less than, or about 5% had a level of less than 5 or less than 12 nanograms. But the risk of deficiency is lowest in that age of 1 to 5, which only had 0.5%. And then it was highest in that group that we saw was low or was less likely to take supplementation. So the 20 to 39-year-olds had a higher rate of deficiency, and then over 60 had a lower rate of deficiency as well. And then there's also a risk by race and ethnicity. Though these studies were done by, they only reported race and ethnicity, not pigmentation. And so the risk is really probably related to pigmentation, but there haven't been any studies that actually looked at it in that way. So this is a big gap, but just something to consider. And just to define vitamin D deficiency and insufficiency, we haven't ever done the studies to prove what a meaningful vitamin D deficiency or insufficiency is outside of, okay, you have this higher risk of rickets and osteomalacia when it gets less than 12. The cut points of 30 and 20 that we've been using aren't really backed by a big clinical trial or a lot of evidence. So that 25 hydroxyvitamin D level that we need to set that point hasn't been established. We also haven't really established if 25 hydroxyvitamin D levels are the best way to determine if you have enough vitamin D. So that also is not been really, we haven't really looked at, are there other markers that may be better to determine if you really have risk of disease? And I think all of that became a lot more relevant when we started looking at the role of vitamin D beyond rickets and osteomalacia, because I think many of us remember about 15 years ago when everything started being related to vitamin D. And we really learned about the fact that there are vitamin D receptors in most tissues, and that the effects of vitamin D in the body are really much more widespread than what we had previously been most worried about. So we know that vitamin D, the receptor, regulates cellular differentiation and target gene expression in many cell types, including the immune system, but also in a lot of tissues that have to do with endocrine disease, including the pancreas and the heart and the kidneys with calcium resorption, we already knew, but even in some of the other functions in the kidneys. So all of that led to a lot of research. A lot of it has been done in immunology and specifically related to inflammation and other things that are going to be related to type 2 diabetes, and with the inflammatory mediators, where vitamin D can downregulate inflammatory mediators. But you also have effects on T cells, which are related to diabetes, type 1 diabetes, and other autoimmune disease, which makes it a lot more relevant for many of our patients. So part of the reason that I thought it would be a good idea to talk about this right now is because the Endocrine Society came out with some new guidelines looking at, should we give vitamin D supplementation to our patients specifically for the prevention of disease. So this was this guideline was really developed to establish a guide for the use of vitamin D to lower the risk of cardiovascular disease and other diseases in individuals without established indication for vitamin D testing or treatment. So it applies to everyone 1 year of age and up. They didn't take on infants since that's much more well established, but it does not apply to anyone with a medical condition that affects vitamin D physiology. Anybody that has hypocalcemia, you still need to measure vitamin D levels and do what we always have done. And then there are some other assumptions that are built in here. So where food fortification is not standard, or the D3 supplements aren't routinely used, then tweaks might have to be made. So I went ahead and summarized the entire guideline in one table so that we can just get the gist of it. And the most interesting thing, I think, is that they recommended that we never really test for 25-hydroxy vitamin D levels. So that is a no straight across the board. But we should give empiric vitamin D to some people, that there may be some benefit. So definitely in the under 1, I added that in for us. Definitely in under 1, it is recommended to prevent rickets, but there is no recommendation that we need to test for those levels. And then even in 1 to 18 years of age, there is evidence that we should go ahead and treat to prevent rickets, and also that there may be some benefit in respiratory tract infections. I did not go into that data here. I didn't think that was as relevant to us. And then in 75 years and up, we'll start supplementation again. So no supplementation between 18 and 75. And there's a decreased risk of mortality is the reason they're recommending supplementation. Pregnancy is probably its own thing as well, so I'm not going to talk too much about that, but there are multiple studies that have shown some evidence that supplementation with vitamin D could be beneficial during pregnancy to both the mom and the infant. And then we're going to talk a little bit about adults with prediabetes. But I think there are a couple of big points on this, and the first is no testing, which is really hard for us because as an endocrinologist, I test everything all of the time. We want to know what we're treating. We want to know how much to give and all of that, because we do use testing to diagnose disease, to monitor disease, and to monitor response to treatment. So this is a little bit of a paradigm shift. But the rationale is really that we don't have cut points to define what a deficiency is or what can prevent or treat any disease. So we haven't really linked that test result with a specific health outcome outside of these few things that I just mentioned. And that's why but even outside of rickets less than 1 year of age, I should say, because even beyond that, the treatment that they recommend is just to empirically dose for people that are at a higher risk, since we don't have clear evidence of what we're treating. How high do I need to get the vitamin D or anything like that? But they were not the first people to say don't test. So, prompted by this very large increase in Medicare reimbursement for vitamin D testing in the early 2000s, the USPSTF put out a report looking at the utility of vitamin D screening and treatment. So they also didn't recommend that we screen with, or that we obtain vitamin D levels, the 25-hydroxy vitamin D levels, for a very similar reason. We might misclassify as disease since we don't have clear thresholds for disease, and that could lead to overdiagnosis or underdiagnosis. And the risk of harm from overtreatment is low. So if you do have someone with vitamin D sufficiency that you recommend supplementation to, the risk of developing high levels that will cause adverse effects is pretty low. So that was the other rationale in there. So I want to talk about the diabetes picture specifically, since that one is closer to all of our hearts. And this is, you have these questions, and then they pop up with, okay, we have a link between this association between lower vitamin D and risk of diabetes that was shown. And so the first studies were that we looked at the effect on the system specifically were in murine models, where initially there was some conflicting data on oral glucose tolerance and insulin secretion in vitamin D deficient rats, where you had some studies showing that there was a worsening in insulin secretion and glucose tolerance if you had vitamin D deficiency, and some studies did not show a difference. But other studies have shown that you can actually improve insulin secretion if you treat a vitamin D deficient mouse with vitamin D. So this would be the dihydroxy vitamin D in that particular study. And then they developed a vitamin D receptor knockout mouse who also showed higher blood glucose levels and lower levels of circulating insulin. And it kind of makes sense. So we've learned a lot about how vitamin D interacts with diabetes. And there is a increased synthesis and secretion. Vitamin D also increases insulin sensitivity. We already talked about decrease in oxidative stress and inflammation. And it does that through multiple ways, but the 1,25-dihydroxy-D binds to the vitamin D receptor in the beta cells directly. And then that activates a cascade of genes responsible for beta cell growth and insulin production and glucose transport. So we've directly tied this back into the physiology, which is really cool. So it also triggers insulin release. It starts the whole cascade, and then can modulate insulin receptor expression, which affects the insulin sensitivity in peripheral tissues as well. So we know that there's a link, and there have been some studies that looked at vitamin D deficiency in adults and supplementation. And this the people who put together these guidelines did their own systematic review. They commissioned a systematic review on this particular topic. And so this data is from the commissioned systematic review for this guideline paper. And the dose that was given for the supplementation varied significantly from 842 to 7,543 international units. And the follow-up range varied quite a bit as well. But overall, they found that there was a decrease. If you gave vitamin D to adults with prediabetes, they decreased the rate of progression to type 2 diabetes. So every 1,000 patients that were treated, 24 fewer progressed to having type 2 diabetes during that study treatment period, somewhere between 6 and 60 months. And it was based on quite a few patients, so over 4,000 patients, and 10 studies were included. Yes.
That's a pretty small number.
Yes.
And I don't know what risk ratios were obtained there, but if you're very low risk ratio, a lot of times it turns out another study shows something else.
Yes, I agree with that. So I'm going to tell you that overall, there were some subgroups that appeared for it to be more beneficial. So the older age, above 62. But then the other thing is the baseline 25-hydroxyvitamin D level. So individuals whose baseline 25-hydroxyvitamin D level was less than 12 seemed to have a higher, it seemed to impact, had a more beneficial effect. But there weren't a whole lot of those patients in this particular study. So it may very well have impacted the risk ratios.
And I one time read a paper that I was very impressed by because they weren't actually looking at this. But what I noticed in the paper, they were comparing Black people with white people, and the Black people had lower levels of 25-hydroxy, but they had the same levels of 125. You know,
yes.
That I was very impressed by that because, especially because that's not the main thing they were looking at, but I noticed it in the paper. So.
Yes, and I think that points out the piece about we don't know if 25-hydroxyvitamin D is the best thing to look at, right? So maybe that 125 is more important since it's, you know, more biologically active, and maybe that's more linked to what we need to worry about as far as risk of disease here. But the committee was impressed enough with the data that they went ahead and made recommendations for the supplementation with vitamin D for adults with high risk of prediabetes. But you can see this is still the strength of the recommendation is only a 2, right? Meaning it is a conditional recommendation where the desirable effect probably outweighs the risk. This isn't a strong recommendation. None of the recommendations in this guideline were a level 1. All of them were a level 2. But they were moderately confident in the effect size, which is our, you know, the 3+ symbols there. The patient population is very specific that that's a high risk prediabetes. So either they have impaired glucose tolerance or 2 of the 3 glycemic criteria, fasting glucose, the hemoglobin A1C, or the 2-hour glucose on the OGTT. So not every patient. Also, what they found in that particular study was even though it seemed like the lower group may have had a better effect as far as the baseline 25-hydroxyvitamin D level, it wasn't a significant predictor of the treatment effect, probably or potentially because it was a low number, but in this study, it was not. And they didn't, and because of that, testing for baseline 25-hydroxy vitamin D level is not recommended in this population, only supplementation. And part of the rationale behind that is for feasibility for people to be able to supplement. So testing adds cost, but it also adds a barrier because you have to go and be tested someplace. And that may make a difference as far as health equity as well, and access. Dosing is a whole nother question. They didn't recommend a dose for individuals that they want you to treat or supplement for any of these. They reported what the ranges are for the studies that they looked at, but they didn't make any recommendations specific for a dose. And there are a lot of pieces that may play into what the dose should be, as far as the frequency of the dosing regimen, what population you're giving it to, and the outcomes that you're looking at. So this particular guideline only made one recommendation specific to dosing. And all it was is that adults 50 and older who need a vitamin D supplementation, we should probably give them a lower dose daily supplementation versus the high dose. It's still a level 2 recommendation, and it's a low effect size, which means they could be wrong. But they only made that recommendation for this age and no other dose recommendations at all. And this was based on them trying to look for studies that specifically compared what happens when you give a low dose daily versus a high dose vitamin D supplementation. And when they did that review, they commissioned a lot of reviews for this paper. But when they did that review, there were only 2 studies that included 537 patients. So they expanded it and said, okay, we'll look at all the studies that also had a placebo group. And that's what they included in their evaluation here. But what they found is that you really don't have any better response when you have a higher dose supplementation. And that in one study, there was the high dose treatment group had a higher fracture risk reported. So that is a potential negative impact from that. No, they were not all in the US. Yes, well, yes, I was going to talk about a couple of these because I think some of the data, the PK data, is really interesting in looking at this. I've seen so many different ways to treat or to supplement with vitamin D, right? We've all seen regimens that are the high dose. We do STOS therapy in babies where you just give a big IM injection of 200,000 to 300,000 international units to treat rickets. You can't get IM vitamin D in the United States, but that is used in a lot of other places. And so there are as many dosing options as people in this room. And so it is interesting to me to say, well, let's look at what we do know as far as the PK data. So this study, now I'm going to try and remember where it was, in Italy. This was not in the US. This study was done in Italy. And it's only 75 people, but it was in adults. And the BMI was 18.5 to 28. So in the normal to overweight group. And they all had a screening 25 hydroxy vitamin D level that was less than 20. So they meet our definition for deficiency in that cutoff. And they looked at 3 different dosing regimens. So this is exactly what you were talking about. They were giving 100,000 units biweekly, compared it to 50,000 units weekly or 10,000 units per day, only for 8 weeks, and then they dropped it to 1,000. And the reason they did that is because they wanted the total dose administered to each of the groups to be equivalent. And that was how they got the numbers to work out. And they treated for 12 weeks. But the reason I think this study is fun to look at is because we can see the timing of how the 25 hydroxy vitamin D levels change in response to that treatment. And so I'm going to try and remember, oh, this will make the pointer go. This is the daily group. If all of you are like me and can't remember group A, B, and C from one slide to the next, I went ahead and put it in the margin here. So the daily group is the one on top, and then the blue line is the weekly, and the biweekly is the green line. The 56-week mark up here is where they dropped from 10,000 units or international units a day to 1,000 international units per day. So that might be in part why you see that decline in those levels. But you can see that response, they all are got above the 30 to 40 nanograms per ml, and we're able to stay at that threshold, though that meaningful threshold hasn't yet been defined. But I think this one, this is the same group of individuals. And so after the first month of treatment, all of the subjects had a level that was above 20 nanograms per ml. So these are the percent of patients who have a level above 20 nanograms per ml, and here's the percent of patients who have a level above 30 nanograms per ml. And honestly, the daily group achieved those target levels at a faster rate than the groups that were on the high dose intermittent therapy, weekly or biweekly therapy. But regardless of the treatment regimen, the majority of patients had levels that were greater than 30 nanograms per ml after the first month. And in 2 months, almost 100% of patients did. One of the things that I was taught is that when we're replacing vitamin D, you need a total of 200 to 300,000 international units to normalize the levels. And so that's part of why I really like this graph, is because it kind of answers that question too. So these are the same groups, they're labeled here where you have the daily, the weekly, and the biweekly. And this is just matching up what the 25 hydroxy vitamin D levels were at the total dose of vitamin D administered. So that it's equivalent, not a time point, but a dose administered. And you can see by the time they got to between this 200 to 300,000 international units is when the majority of them were above the 30 nanograms per ml. So one of the other, this particular study, this is a different study, but, oh, sorry, no, it's not. This is how they interpreted that one. And they said that maybe you can maintain higher vitamin D levels with daily dosing versus the intermittent dosing. And they're D3, all were D3. Sorry, I should have put that on there. Thank you for asking. So this particular study did not look at any clinical outcomes, but there are some studies that looked at clinical outcomes that showed that maybe daily versus intermittent dosing, that daily was a little bit better for the clinical outcomes as well. I'm not going to dive into those, but this particular study was I like because it measured the vitamin D levels a little more often. So this study was, again, a similar age group. Everybody at baseline had a 25 hydroxy D level between 10 and 20. It was only 60 people. And then they compared 20,000 units daily to 50,000 international units every 25 days. So a little bit different than the last one, but they measured the levels 4 times in the first week. So this graph shows the change in serum 25 hydroxy vitamin D level. So not the absolute level, but this monthly regimen is the blue line. So you can see, as you kind of would expect, when you have that big initial dose, you have a more rapid change in the serum 25 hydroxy vitamin D level. But similar to the other study that we saw, the daily regimen seemed to achieve slightly greater change in serum 25-hydroxyvitamin D levels. And I think that the reason I find this so interesting is because we often will see people do a loading dose of a vitamin D replacement. And sometimes we get called for kids that orthopedic surgery really wants to fix their vitamin D level really fast so they can do surgery. I don't know if you all get those phone calls as well. And so we do loading doses in them. And so I think that's, do what? Oh, I can't recommend tanning beds to my patients, but yes. It would. Yeah. So this is the last study I'm gonna run through really fast, but this was done in that research network that Dr. Wintergers mentioned that we're a part of. So which is so this is a multi-center study looking at pharmacokinetics of vitamin D in obese children. So a very specific population. And honestly, the impetus to do this study was that at the time, there had been a study looking at does vitamin D improve asthma outcomes in kids. And there were some studies that said, oh, maybe, but you need to get their level above 40, and we can't reliably do that in individuals with obesity. So we were trying to figure out, well, how much vitamin D do you need to give them? You know, we really don't have any PK studies in kids. So we did this study, and then I'll just share with you that while we were doing this study, another paper came out and kind of disproved that whole vitamin D and asthma in kids. So we did not do the follow-on study, but we did do the PK study for kids. So they all had a baseline. Oh, and I'll tell you, the centers for this study varied geographically from Hawaii and New Mexico to South Dakota, Rhode Island, Delaware. But we did do this. We participated here and enrolled kids as well. So at baseline, everyone had a 25-hydroxy-D level that was 10 to 30, and then our target was to get them above 40. So there are two groups here. This group got a loading dose of 50,000 international units and then 8,000 units a day, and then the second group here got 600 international units a day, which is just the recommended daily amount. That was the control group. There were other groups. We did an initial small group of for a dose finding study, and I didn't put that data on here. But after the dose finding study, the 50,000 international unit loading dose outperformed that with the 8,000 daily. So there were other doses evaluated. And the treatment was only for 16 weeks, and then there was a 12-week follow-up period since it was to get PK data. And the reason I wanted to bring this one up is this area right here. So we were able to get most of the kiddos levels above 40 nanograms per deciliter, except those with more severe obesity with their BMI Z-score of 3 SDs or greater. That was a little more challenging to get them above 40. However, weight did have a big impact in the half-life of the vitamin D, and this was all D3. So I thought that was really interesting. So for individuals who were in the overweight category by BMI Z-score, the mean half-life was 117 days. For those who were in the obese, up to 3 SDs, their half-life was about 80 days. And then those who were in that severe obesity group, the half-life was only 46 days. So I thought that was just interesting. And then we've talked a little bit about the adults with dark complexion or individuals with dark complexion being at a higher risk. And I will say that was because it's something that we think about a lot. I just wanted to mention it was addressed in the guideline. And they pretty much said what we've already talked about. We reported race and ethnicity. That doesn't mean we've reported skin tones. There are no trials that have examined if screening or treatment deficiency improves outcomes or if skin complexion changes any of that. So no, you should not test people just based on that particular risk factor. This is another ad for VIMS vitamins because we've kind of come full circle. So we're not going to test, but we are going to treat youth and individuals above 70 and then some specific populations with empiric vitamin D supplementation based on this. So we still like our supplements. But there's a whole lot we don't know. And since there's so many researchers in the room who probably know more about this than me, I just wanted to mention a couple of really important areas that need to be addressed by research. So we really need to know what the best way to measure vitamin D deficiency is and what meaningful cutoffs are for these groups. And we need those things before we can really do studies to find out if vitamin D improves asthma outcomes in kids or any other beneficial effects of vitamin D. So these are the take-homes that we've talked about, but really the evidence to support dose recommendations is very limited. So there are no specific recommendations. But testing is not recommended as that threshold. And you know, when you look for pictures to put on presentations, so many quotes pop up. Almost a lot of really great thinkers, Aristotle, Socrates, Einstein, they all have these quotes about what we don't know. And I think that's very relevant now because there is so much we don't know about vitamin D. Partly because we figured out like it helps with rickets, it helps with bones, and we started giving it before we really even had a format to do clinical trials. So a lot of opportunity for us to learn more. And that is it. That's our CME code for today. Thank you all. With what, sorry, with what being popular? Oh man, I feel so guilty every time people are, like relatives are like, oh, I used to have to take that every day. Oh, at least we have pills.
So. It's a.
Hmm?
This is logic measure of. So in these studies, does the PTH also look back?
Good question. In some of them, the PTH was looked at, but not in all of them. And so they didn't talk too much about the those specific studies where they came up with the 30, but I will say Endo Society used to use that as their threshold, and now the Endo Society says there's really not enough data that is meaningful with just the PTH rise.
I would say that maybe 30 years ago, I remember reading that everybody that lives north of Atlanta is vitamin D deficient. And at that time, of course, people may not remember this because there are some people here that probably are not 30. And this was 30 years ago, okay? But in any case, and that was a time when everybody said you have to test for vitamin D. Of course, everything has turned around completely now that people have got more knowledge about what actually is going on. And like the first test that we had at the VA hospital was inaccurate, but everybody was ordering vitamin D, and we couldn't send them all out. And I remember setting a reference range for whoever wanted to look at it for 15, because that was the range that I realized would be okay for that test. Now, in about 6 months, they came out with a revision of the test that was actually accurate. So, that kind of solved that problem. But and this has been going on for many, many, many years about vitamin D. And those are just some of the things that I saw over the period of time. And I would also say this, that some years ago, I wanted to win the best abstract at a meeting. It was a pretty big meeting. And I knew I had a very good project, So I put my name first and the postdoc's name second, because they always invited the person that was first, which I've never done before or after. But in any case, the main speaker at that, and we did win the abstract. And so we were at the award table, and the main speaker sitting next to me was Hector DeLuca. And that was one of the most exciting and satisfying evenings of my life. And I spent the whole evening gabbing with Hector DeLuca. And I probably never shut up, so like I'm doing now. But so he probably got an earful. But anyhow, I'll always remember that evening sitting next to Hector DeLuca for about 3 hours.
The question on the check.
Yeah, I was just looking, it looks like someone had shared that there's a expanding literature on vitamin D and lymphoid cancers and overall immunodeficiency. And it seems we need secondary physiologic parameters to correlate with vitamin D deficient states, especially in immunology. Did you want to share anything more about? I don't know how to make it so you can talk.
I'm not sure if you can hear me, but
yes.
in our world of cellular therapy, CAR T therapy, TILS therapy, as well as the treatment with checkpoint inhibitors, there are many that now automatically supplement and measure the levels. And there are, I submitted this review article of this that has found correlations and recommendations for this. But we desperately need secondary indicators of what these vitamin D deficiency states do in immunology. Measuring levels is probably insufficient for adjusting for this effect. And again, it's not only for the effectiveness of all these cellular therapies, but the actual onset of lymphoid malignancies that seem to be correlated with deficiency states of vitamin D. This is a very underserved, under-researched area, and it's desperately needed to not only justify what we do now, but obviously improve the cancer immunosurveillance that leads to higher rates of cancer, because decreased immunosurveillance is correlated with cancer onset, as well as now therapy of cancer, because T cells have now become very much a frontline therapy and a second-line therapy for not only liquid but solid tumors now. And the optimization of T cell function in adults is seemingly correlated with vitamin D levels, as well as other senescent issues.
Thank you for sharing. That's really interesting. Yes.
I have a question about that article with the half-life of vitamin D in the obese, and then different gradations with the lowest half-life in the most obese children.
Yes.
Well, so is that a matter of absorption, or is it metabolism in the liver? Do the children have NASL? And then what about gut microbiome? Is there anything that correlates with those parameters in your most obese children in that study?
That's a really good question. Gut microbiome was not measured. I can't answer the absorption question for you, but I can get the data and share it. Yeah. Yeah.
So that thing is in the cell and it's not in the supplement.
Yeah.
So.
Correct.
Like, does it affect what's in the blood versus what's?
Correct. But then the question is, how does that relate back to bioavailability for it to be active? And then so there have been, and I didn't include this, but there have been some studies that have shown that all of that stored is probably that the what's bioactively available, or like what's available for the body to access, is probably also deficient. So that kind of storage sink is not as functional of a reservoir as we had hoped. But how great of a study that was, I can't speak to, because I read that several years ago. All right, let's